Today we are going to discuss on the topic cohort study. These are the topics that we are going to deal with. Cohort study is also known as prospective study or longitudinal study. It has three distinct features. The cohorts are identified prior to the appearance of the disease under investigation. Second, the study groups are observed over a period of time to determine the frequency of disease. And third, the study proceeds forward from cause to effect. Cohort study is an analytical study undertaken to obtain additional evidence to refute or support the existence of an association between the suspected cause and disease. The concept of cohort, it is defined as a group of people who share a common characteristic or experience within a defined time period. Thus, a group of people born on the same day or in the same period of time form a birth cohort. Persons exposed to common drug, vaccine or infection within the defined period constitute an exposure cohort. So, pregnant women, they form a cohort. Children under 5 years form a cohort. Men with HIV form a different cohort. So, for a cohort study, we take people who are exposed and unexposed, and over time we compare the incidence of disease. Types of cohort study. 3 types of cohort studies have been distinguished on the basis of time of occurrence of disease in relation to the time at which the investigation is initiated and continued. It is divided into prospective, retrospective and combination of both. So this picture explains the types of cohort study. In prospective study, we start from present and then we go to future. In retrospective, we start from past and we reach till present. And in combination, we start from past, reach till present and then we follow up till future. What is a nested case control study? In this concept, a case control strategy will be used, but it will be conducted within the context of a prospective cohort study. This is referred to as a case control study nested within a cohort study. The advantage is it is less expensive. The nested case control design is often used when the exposure of interest is difficult or expensive to obtain and when the outcome is rare. By utilizing data previously collected from a large cohort study, the time and cost of beginning a new case control study is avoided. What are the steps in case control study? There are 5 steps: selection of study subjects, obtaining data on exposure, selection of comparison groups, follow-up and analysis. Selection of study subjects. Subjects are usually assembled in one of the 2 ways. One is general population, second is special groups. In special groups, we further have select groups and exposure groups. Select groups meaning professional groups, insured persons, government employees, college alumni, etc. Exposure groups, special exposure to physical, chemical and other disease agents. Example, radiologists exposed to X-rays. Next is obtaining data on exposure. Information about exposure obtained from either from cohort members through personal interviews or mailed questionnaire, or through the review of records, or from medical examination or special test, or through environmental surveys. Information about exposure should be collected in a manner that it will follow the classification of cohort members according to whether or not they have been exposed to the suspected factor and according to the level or degree of exposure. Next step is selection of comparison group. We can have internal comparisons or external comparisons or comparison with general population rates. In internal comparison, we compare it within the group. In external comparison, we compare with a different group, and if both are not available, then we take comparison from the general population. Next step is follow-up. One of the problems in cohort studies is the regular follow-up of all participants. The procedures used are periodic medical examination of each member of the cohort, reviewing physician and hospital records, routine surveillance of death records, and mailed questionnaires, telephone calls, home visit, etc. However, in spite of best efforts, a certain percentage of losses to follow-up are inevitable due to death, change of residence, migration, or withdrawal of occupation. These losses may bias the results. It is best to achieve as close to 95% follow-up as possible. Next step is analysis. The data are analyzed in terms of incidence rate of outcome among exposed and non-exposed, estimation of risk of outcome done in terms of two indices, that is relative risk or risk ratio and attributable risk or risk difference. Incidence rate of outcome among exposed and unexposed can be calculated using this table. So incidence rate among tobacco chewers is 4.5 per 1000 according to this table, and incidence rate among non-chewers is 0.5 per 1000 according to this table. Estimation of risk. Estimation of risk of outcome in the exposed and non-exposed cohort is done in terms of two indices, relative risk or risk ratio and attributable risk or risk difference. Relative risk or risk ratio is the ratio of incidence of the disease among exposed and the incidence among non-exposed. It is calculated by incidence of the disease among exposed divided by incidence of the disease among non-exposed, and this example where we have seen it is relative risk is 9. This implies tobacco chewers are 9 times at higher risk of development of oral cancer compared to the non-chewers. Estimation of relative risk is important in etiological inquiries. It is a direct measure of the strength of association between suspected cause and effect. A relative risk of 1 indicates no association. A relative risk of 2 indicates incidence rate of disease is 2 times higher in the exposed group as compared with the unexposed. The larger the relative risk, the greater the strength of the association between the suspected factor and the disease. It may be noted that risk does not necessarily imply causal association. Next is attributable risk or risk difference. It is a difference in incidence rates of disease between an exposed group and a non-exposed group. Usually it is expressed as %. It is calculated as incidence rate of disease among exposed minus incidence rate of disease among non-exposed divided by incidence rate of disease among exposed. In this example, it is 88.9%. Attributable risk indicates to what extent the disease under study can be attributed to the exposure. Out of the total risk of development of oral cancer in chewers, 88.9% is attributed to tobacco chewing in the hypothetical example. This suggests the amount of disease that might be eliminated if the factor under disease or under study could be controlled or eliminated. Next is bias in cohort studies. Basically, we can divide it into 3: selection bias, information bias, and confounding bias. In selection bias, we have follow-up or dropout bias and selective survival bias. In information bias, we have diagnostic bias and Hawthorne effect. Coming to the advantages of cohort study, incidence can be calculated. Several possible outcomes related to exposure can be studied simultaneously. It provides a direct estimate of relative risk. Dose-response ratios can be calculated. And since comparison groups are formed before the disease develops, certain forms of bias can be minimized, like misclassification of individuals into exposed or unexposed groups. Next is disadvantages of cohort study. It involves a large number of people. It takes a long time to complete the study. Certain administrative problems are inevitable. It is not unusual to lose a substantial proportion of the original cohort. They may migrate or lose interest, etc. Selection of comparison groups which are representative of the exposed and unexposed segments of the population is a limiting factor. There may be changes in the standard methods or diagnostic criteria of the disease over prolonged follow-up. It is expensive. The study itself may alter people's behavior, which is known as the Hawthorne effect, and there may be ethical problems may be faced during the study. So these were the contents that we have covered till now. Other names, 3 distinct features, indications, 3 types, nested case control study. Then we discussed about the steps, 5 steps: selection of study subjects, obtaining data on exposure, selection of comparison group, then follow-up, analysis. In analysis, we discussed about incidence rate of outcome, estimation of risk, that is relative risk and attributable risk, 3 types of bias, that is selection bias, information bias and confounding bias, advantages and disadvantages. So these are the references. Thank you.